Okay, well, it's my pleasure today to introduce Dr. Rashed Alrashed. He's joining us from Hamilton from the McMaster GIM Fellowship Program. He's PGY5 there. We're lucky to have him this block for POCUS at University Hospital. And at the end of his rotation, Rashed has a teaching presentation for us about pleural effusion on ultrasound. So I will give the microphone over to you now.
Thank you, Dr. Jeff. It's a pleasure to be here actually doing this rotation with experts in POCUS at Western University. Today, I'm going to talk about pleural effusions in ultrasound, and it's going to be like a topic review. Hopefully, we get an idea about assessment of pleural effusions using point-of-care ultrasound. What to expect? We are going through going through some comparisons between different modalities in assessing pleural effusion, and I will talk about how to get proper views for pleural effusions and what appearance consolidation might indicate and reflect, and some signs that worth identifying, and what could this effusion be based on appearance, and we'll go for volume estimation, which is quite a bit interesting, and whether or not direct or supine is superior in assessing the volume of effusions. So pleural effusion is it's a common finding in admitted patients, and it can be related to different variety of differentials, as you can see in this table. I mean, that's a lot of differentials that can cause pleural effusions, and the incidence of pleural effusion decreased after discovery of antibiotics, but unfortunately, it's now climbing up. And this is an interesting article about incidence of empyema in Canada, and they have conducted a study over 11,000 patients admitted with empyema and found increase 2.2-fold in incidence between 1995 and 2003. That's in patients less than 19 years of age, and 1.2-fold increase in patients aged 19 and above. And this brings up the physical examination and detection of the pleural effusions. And you might ask a question, do we really, rely on physical examination only into assessing or to rule in or rule out pleural effusions? And this study, actually, they had done a great job actually in reliability testing and correlation between agreement between physicians when assessing a pleural effusion based on physical examination. And what they found actually that some signs like asymmetric chest wall, vocal phrematus, dull percussion, decreased breaths or absent breath sounds, they tend to agree, physicians, when they examine the patients with a CABA ratio above 80%. Yet still there's a blinded spot for discrepancy into assessing pleural effusion based on physical examination. And other signs with crackles or pleural rub, these actually has some more discrepancy. As you can see, even for pleural rub, they were actually doing horrible into identifying that sign in the clinical examination. The bottom line is physical examination is good to rule out, but not to rule in pleural effusion. And think about it. I mean, if the pleural effusion is like mild, moderate, or trace, you wouldn't be really able to find that. And based on a humble experience, Most of effusion can be detected by physical examination when you have like moderate to large effusions. And that brings actually the importance of imaging in assessing pleural effusions. And now we talk about comparison between imaging tools. As you can see here, chest X-ray has a variance in sensitivity based on view and fusion size. But roughly, sensitivity can be estimated to be 54% for the chest X-ray, and it do so much horribly when you do a chest X-ray anterior posterior view. However, the specificity is a 92%. And just a reminder about sensitivity and specificity. Sensitivity is the true positive, and sensitivity is the true negative. Ultrasound, however, it has a good sensitivity of 93% and can reach up to 100% of sensitivity for effusions more than 100 ml, which also can exceed the sensitivity of CT scan, which is considered as a gold standard when the effusions are more than 100 ml. Specificity is also considered to be excellent of 96%. The CT has good sensitivity and specificity of 98%, as we mentioned before, as it's this is the gold standard. And here we'll talk about the advantage and limitation of each imaging modality. The chest X-ray available almost everywhere and can detect fluids more than 50 ml lateral upright view. And this changes dramatically when you do like posterior anterior view only, as you need more than 200 ml to be easily detectable on chest X-ray. But there is a limitation. It can miss up to 10% of paranumeric effusion. And the bronchial opacities that's seen on anterior posterior view could be an effusion that's missed. In terms of ultrasound, it's a quick and bedside and can guide the management just quickly on the spot, and can detect pleural effusion of 20 ml easily. And for someone who has like expertise with trained eyes, who can detect up to 5 ml of effusions, I mean, easily as well. But it's the limitations in ultrasound. It's really, I mean, comes in on like the operator experience. So this is the major limitation of ultrasound in assessing pleural effusion. And the other possible, I mean, limitation is the availability of instruments and machines. For the CT scan, it's the most accurate, but it has some limitations, which is, I mean, cannot distinguish between small effusions and pleural thickening independent areas. Also, it cannot differentiate between atelectasis or small effusions as well. It has low sensitivity in detecting pleural fluid septations, which, I mean, ultrasound in this situation comes handy. Also is the radiation exposure. As you know, one CT scan equals to 350 chest X-rays. The question, why focus on ultrasound for lungs? So it's fast, reliable, helping into clinical decision-making, can quantify and characterize the pleural fluid. Also, we can be used for monitoring of therapy, and whether or not, I mean, making a decision regarding drain or not. It has no radiation, and it is seems to be convenient also for patients. You don't ask them to take deep breath, hold breath, retesting with imaging, taking another shot, burning films. It's more convenient. They just breathe normally while you're assessing for pleural effusion. But as we mentioned before, it's operator dependent, and this brings up how to acquire proper views for pleural effusion. we have, I will not go through all, assessment of lung ultrasound, how to look for, identify findings, but I will focus on some of areas. As you can see in this beautiful image, you have some point which you go into assessment, the point number 1 to the point number 1, which is, the secondary coastal space, midclavicular line, point 2, anterior axillary line, and point 3, it's as well the posterior axillary line, and point 4. We tend to use the phased array probe, and why? Because it's really, gives you a good vision and high quality, high detailed images. And I think it's one of the ways to use it. Using it probably would be giving you appropriate impression about the effusions. Also, another good thing about using a phased array is that you don't really get obscured by the ribbed shadow compared to curvilinear probe. So this is another benefit from using the phased array or sector probe. Again, this is just for anatomy. As you can see here in the midclavicular line, point number 1, number 2, it's going to be like just lateral to the nipple, and number 3 at mid axillary line. Number 4, which we call blabs, is goes into the posterior axillary line, and further beyond that. So number 3 is what we call the costal phrenic view. But you might ask how to know I am doing the right plabs view, and this also shows an image about it, which location you expect it to be looking at into the dependent areas. As you know, the Blue protocol, they have like some suggestions into identifying the blabs view, and just imagine there's the upper blue point, lower blue point. So imagine drawing a line from the lower blue point, just vertically going down, and just crossing the posterior axillary line. Start from the posterior axillary line and go down, sliding posteriorly while the probe knob looking at patient head direction. This is just proposed way to get into blabs view or point if you're not sure about where's the area. So also keep in mind to use labeling in lungs ultrasound all the time, because it's sometimes difficult to know which area, and think about anatomy and probe orientation. Make sure that you are doing the right way into orientation. Find the landmark, optimize with small movements. You can use tilting, rocking a little bit. Always imagine looking for the lung. So this is the way into like optimizing your views. Now we'll go into the anatomic boundaries in ultrasound for dependent areas. So this is from, as you can see up there, there is a labeling, right costal area. What you see here is that you can see here is this is a kidney, this is the liver, this is the diaphragm. So you got your starting point. You know where you are right now. Then you proceed afterwards, looking more into the lung with small adjustment. As you can see here again. So this is the same. The liver here is going to be the kidney, and this is the diaphragm. Here is the aerated lung. This is for the left side. Here you can see the spleen, and again diaphragm and aerated lung. So this image depicts the anatomy. So this is the soft tissue. This here is the chest wall. This is the liver. This is the kidney, as we mentioned before. This is the diaphragm and the lung curtain. And you might ask, what is the lung curtain? It's a normal finding. As you can see, this is what we call a lung curtain. It's an air within descending lung obscuring the area above the descending diaphragm during inspiration. Again, this beautifully show the curtain sign, and this is a normal finding in assessing lungs in ultrasound. Checklist for assessing pleural effusion. Try to focus on the mid to posterior axillary line with adjustment for window of supine. Always think about the chest wall. Look for diaphragm, orientation organ, that's like an anchor for you to adjust your window. Look for anechoic area, which indicates there is something as pleural effusion. If it's positive, find lung and look at the lung characteristics. Look for consolidation and look for other associated signs. The areas that you might find pleural effusion. You can look at the posterior lateral costophrenic places in semi-recombinant or seated patients, or like either the erect position, but it can be superior as well in loculation. So still, it's important to look into other areas of in lungs ultrasound. It can be also anteriorly and mechanically ventilated patients in prone position. And this what happened during COVID outbreaks, when they were some patients having like on top of that pneumonias or barometric effusions. So this is again showing the posterior area, as we mentioned, for area to look for pleural effusion. As you can see here, the anechoic area revealing the pleural effusion. However, as you mentioned, you always go up and look for other areas. This is at level 1, and you can see septations in the pleural effusion with loculations. Again, another view for L1, and when you descend down, you still see that up to the lung base. So looking for associated consolidation, you look for hepatization or consolidation and air bronchogram. You might look for the consolidated lung tip in relation to pleural effusion, which is really important into deciding whether or not this is likely consolidation because of pneumonia rather than atelectasis. And this is a good way to give you an impression. If the consolidated lung is smaller in size compared to effusion size, this represent likely compressive atelectasis. And we'll go now for an examples. And the vice versa, when the consolidated lung is bigger or larger than effusion, this might reflect a pneumonia and barometric effusion. Excuse me. Here, as you can see, the hypoechoic area here, this is a pleural effusion. So this is the lung tip. Compared to the size, this one to the consolidated lung, this indicates this consolidation likely to be compressive atelectasis. Whereas in this view, you can see, the size of consolidated lung, it's look like a tissue, and the size of it is more than the effusion size, which might indicate this likely to be baroneumeric effusion. And this brings up the signs that we need to identify in the assessment of pleural effusion and consolidation. We'll start with the jellyfish sign, then we'll go for other signs, which is worth looking at and know about it. Jellyfish sign is named based on the jellyfish. As you can see, this tail of the jellyfish, just imagine how these swim in the sea, deep sea, and this is almost the same. they found that when you find this jellyfish sign, it's likely, highly likely, this consolidation, consolidated lung tip is caused by compressive atelectasis. The spine sign, this sign has sensitivity and specificity 73 and 92% respectively. And how to identify spine sign is you need to do some adjustment of your view and distance, depth of your probe measurement, and try to, when you go down the costal area or the blabs area, not on the blabs area per se, just a little bit superior to blabs area or the costal area, and then point your probe toward the spine. This, as you can see here, this is the spine shadows, and in normal aerated lung, when you have diaphragm ends here, start from here to the aerated lungs, you should see this goes away once patient takes an inspiration. But here, while patient taking us the inspiration, still we see the spine reflection. This indicates this is an effusion with a high sensitivity. Plankton sign. Plankton sign is when you see circular motion of debris in the effusion. We found that it's likely represent exudative effusion. However, this can occur, the debris in prolonged transitive effusion. So we are not, it doesn't mean 100% this is an exudative pleural effusion. An air bronchogram. Air bronchogram is divided into static and dynamic. If you don't see movements inside the lung of hyperechoic areas, then this indicates this is static air bronchogram. Whereas if you see the movement, small subtle movement of that, it with respiration cycle, it indicates a dynamic bronchogram, which might reflect a pneumonia. So they had the study comparing both the dynamic and static air bronchogram, and they found that the static air bronchogram can be seen mostly in resorptive atelectasis, but 1/3 of cases they have a pneumonia. Whereas if you have dynamic, it's indicating a pneumonia. This depicts both static and dynamic. You see the subtle movement in this area. This is called dynamic air bronchogram. Shred sign. Just remember the shredding machine and the papers, shredded papers. When you see irregularities in pleural line, and you see horizontal lines like the shredded paper, this is called shred sign. And this indicates an alveolar consolidation and not complicated consolidated lung. This brings now how to quantify the pleural effusion. We have two modes for quantification. We have qualitative method and we have quantitative. The qualitative, based on what you think, what you see on the screen. If it's like minimal, it's going to be like in costophrenic angle only. If it's small, exceed costophrenic angle, but you still can see area of the lung, and you can see, it's all within the range of the probe, while moderate reaches up to 2 probe ranges. Difficult to know where is the lung. In large, you don't see it, just like a hypoechoic area all over. While in quantitative measurements, we have two two positions, supine or semi-supine and erect. In supine, we have methods called Balick, Eichenberger, and Remirand, while in erect, we have Goki and Asta. And we'll go through each one of these in details and see how they correlate with estimation of and the drainage of pleural effusion. First one is the Balick. So your patient is going to be supine, and he's going to be elevated 15 degrees trunk elevation, and you're going to use a sector or multi-phase array probe. The probe is going to be perpendicular to the dorsolateral chest wall. And you ask the patient to take a deep inspiration, then do like full expiration, and you take the measurements, but at the end of expiration. So the probe is going to be transverse, and the indicator is pointing up to the sky. What you measure is you're going to measure the distance between visceral and parietal pleura in millimeters. And the equation is going to be pleural effusion volume, milliliter, is distance in millimeter multiplied by 20. They have done this study in ICU settings, and they were quantifying the effusion size estimation based on what they do when they drain it. And they found that the correlation factor to thoracocentesis was 0.72. In Eichenberger method, also they have done this in ICU settings. Patient is supine. It doesn't have to be elevated, trunk elevated 15 degrees. Again, transducer is going to be vertical to the chest wall, but you're going to use curved probe, and again, the indicator pointing up to the sky. In Eichenberger, there is one issue with it, is that you ask the patient to take the maximum inspiration, and you know that in sick patients, most of them, they won't be able to follow you into taking like a deep inspiration. And the operator in this way going to measure the maximum distance. It's going to be in millimeter between the lung and posterior chest wall. So this is different from Balick, which is like visceral and parietal pleura. The effusion calculation is a little bit complicated. The equation is like 47.6 multiplied by distance minus 837. So they were trying to think about it like a circle, like the effusion is like a cylinder, and then they were trying to roughly estimate how it's going to be the effusion based on this equation. And interestingly, the correlation factor was 0.8 with this method. However, you cannot use this for small effusions, because you will get a negative value sometimes when you do that on very small effusions. And then the other way to do it in ICU settings, you can, or in step down unit, you can do the Balick method instead. So this is a quick recap for the two methods, both supine, Eichenberger max inspiration, while in Balick in expiration, both transverse view, pointing up to the sky. And you can see here in Balick, they measure like visceral and parietal pleura, whereas in Eichenberger from lung to the posterior thoracic wall. The third method, also which is in supine position, is the Remirand. Remirand also uses the curved probe. Patient's supine should be 0 degrees. Again, the probe is pointing up to the sky, and you're going to be taking the measurement at the end of expiration. So this has like two things to do. You need to measure first the extension of pleural effusion, which is the length, and then you take a midpoint between the start of the effusion to the end of the effusion, and then try to take a transverse cut, like circular motion, cylindrical motion, to estimate the area. This image depicts the method. You take the upper limit, take the lower limit, then this is the length, and then you take the midpoint, do your like scanning. It's like scanning the CT scan. You take like an area, and then you measure the volume. It has a correlation of 0.84, which is quite good actually, but it's still, I mean, operator dependent and lengthy procedure. The other method is Goeki method. It has two formulas, both done in erect position and using curved probe pointing up to the head. The measurements are taken in centimeters at end of expiration. This, by the way, Goeki method done in ward and outpatient setting. So the first formula is going to be like taking the lateral height of the effusion. So you take the lateral height of the effusion first, then you take the second from distance between lung base and the mid diaphragm, which is so you take both readings, and they have found that the correlation for the first method, which is, I mean, the lateral height correlates 68, while taking the height depth correlates with 87 with thoracentesis. The last method is the ASTA, and this is done in patient post cardiac surgery for validation, and it's used in this method the sector probe or the multi-phase array probe pointing up to the patient head, patient erect, mid-scapular line, and you measure the distance in millimeter between the visceral pleura and the mid diaphragm. As you can see here, from the visceral pleura to the mid diaphragm, and then you take the measurement based on that. And the measurement is equation is what you measure in millimeter multiplied by 16, and the correlation with thoracentesis was 0.79. I mean, this brings a question: which position is better, supine or erect, in assessing, I mean, quantification of pleural effusion? First, I mean, it's about the patient condition, and is patient able to follow your command? Is patient going to be feeling well to take a deep inspiration or do full exhalation and do the measurements? So it's multifactorial when you can do which procedure you can do. However, some actually did a good study into to compare 4 formulas into assessing pleural effusion, which is quite interesting. And they have done this study in population like our patients in internal medicine, while they are just, I mean, in the wards or in the clinic. which is I mean reliable, since we are comparing what we can do in end inspiration or end expiration, which seems to be most of our patients would be able to do that. So their methods of the study, they have applied the 4 formulas, or they did actually direct Gecko and they did supine, Balick and Eisenberger. They had 32 patients with pleural effusion. They were spontaneously breathing, 50% left-sided, all unilateral effusions. And they had it, as you mentioned, 1 indirect, Gecko 1 and 2, and then supine. They did Balick and Eisenberger. And how they do correlation, they use the closed tube thoracostomy drainage using 28 French chest tube. And they were comparing the estimation to actual drained fluid. And the mean total volume drained was about 2.7 liters, plus minus 1.8. The exclusion criteria for this study was located effusion, patient at extreme point of life. They couldn't sit, direct, or obey breathing instructions. Those with thoracic deformities, diaphragmatic pathology, or previous chest surgery. Interestingly, the finding, if you can see here, these are the subjects, and those with the right side effusion 16, with the left side effusion 16. If you look for volume drained in the Rect 1, Rect 2, this is Gecko 1, Gecko 2 equation, compared to volume drained. I didn't do, I mean, an impressive work into, I mean, estimation. Still there is, I mean, high chance of like standard error. Also with the supine, interestingly, Eisenberger, which is the supine one, came quite close actually in right-sided diffusion, whereas Balick, it failed badly. In left-sided diffusion, again, Gecko didn't do that impressive work into estimation, despite, I mean, if you remember, Gecko 2 was superior into correlation with 87 with racosynthesis based on the study when they demonstrated their way, which is didn't really do well here. Whereas here, Eisenberger, again, in left side diffusion did quite well. It's almost equal to what they drained to estimation. Balick comes second, but it's not really impressive again into assessing the left-sided diffusion. And this really brings the correlation with racosynthesis. So that was just an overall view of the previous table, but this one really brings up the correlation. In the right side diffusion, as you can see in Rect 1 and Rect 2, the correlation wasn't that impressive. Also, in supine, which is, I mean, Schroberger and Balick, failed badly in right-sided diffusion. Whereas in left-sided diffusion, Eschenberger and Balick excelled very well, actually, as a correlation to the estimation of fluid. While as well also Gecko did well into that one as well. So you might think why right-sided seems to be, I mean, our estimation fails almost badly. We think it's because of usually raised right-sided, I mean, right hemidiaphragm, liver size can change, I mean, congestion of the liver, I mean, multifactorial compounding factor that can affect the estimation, which seems to be very evident in this study. In conclusion, use qualitative methods, and if it's moderate, consider quantitative. I mean, methods validated and moderate to large effusions, and that's why we say better to use it when it's like when you see it like qualitatively moderate to large. Try to avoid using it in small effusions. These are not 100% accurate, and depends on patient condition, how he or she obey your instructions into inspiration, expiration, and also it's hugely operator dependent. The choice between erect supine, again, it's situation dependent, and also we as a physician tend to use easiest and fastest way to get, estimation, because time is limited when we're doing rounds. In Geico 2, it's correlate the best in erect with value of 87, whereas Remirand comes second in supine with correlation of 0.84. Balick, Eisenberger correlate well both supine and left side effusion. So when you decide to use quantification, just think of that. If it's left effusion, you can do it supine for patient. Use Balick or Eisenberger. Both works well. Whereas in erect, you can use Geico 2, which is like is accurate compared to Asta. As you remember, in Asta, it wasn't really correlating very well, despite it's easy, and the calculation was easy in Asta. But keep in mind, it's not really accurate. And the next method could be discovered by you. And thank you very much for letting me have this opportunity to present this topic review.
Well, thank you, Rashed. Thank you for presenting all the evidence behind pleural volume estimation and other pleural volume associated signs in great detail, because I think at Western, we do tend to try to measure or at least estimate the pleural volume quite a bit in our POCUS community. And it's certainly important to understand the evidence and certainly the limitations behind these different estimations. I was wondering, for the sake of demonstration, could you go back to your slide that demonstrated like that classic pleural effusion with the jellyfish sign? Sure. I wanted to sort of fix it just for demonstration, sort of figure out some of these different methods. Yeah, and you can just maybe play that. So this is a pretty classic small to moderate pleural effusion. We don't have any depth markers here, but I'll just try to annotate on your screen here that if we are talking about different methods of measurement, we need to just be a bit clear on what we're doing. So often we are teaching this method of measurement where we draw a line from the middle of the diaphragm and horizontally, or technically up on the patient towards the lung, and we sort of take that distance and we multiply it by, actually, we keep it simple, and we say we multiply it by 20, or I guess it would be 200, depending what the measurement was, millimeter or centimeter. And that's kind of it's a little bit of a mixed application of two different methods. There's the USA method that you mentioned, where we are looking at the long axis of the lung. We're getting this measurement. The patient is sitting upright. We take this measurement and we multiply by actually 160 as the equation. When we say we're measuring by 200, that's actually the Balick method. And in fact, this is not the correct way of doing it. And I find that we are doing this a lot here at Western, where we just take this measurement, multiply by 200, and we call it a day. Yeah. At the end of the day, we are just estimating the pleural volume. We're not expecting to be perfect to the millimeter of how much volume there is in the patient. And I do still think it's a valuable thing to do quickly, just to get a rough sense of what's in there, because the qualitative appearance of a pleural effusion may be quite deceiving if you don't just quickly quantify it. And it's helpful that I think we've all kind of been there, where we're doing thoracentesis, everything's going well, and then all of a sudden the drainage stops. Okay, well, is it because we're done drainage, or is it because the catheter might be abutting against the descending lung, or abutting against the diaphragm, or abutting against some other structure, and all you can do is just manipulate the catheter a little bit? And so at least for me, I often see that situation. I maybe jiggle the catheter around a little bit, or maybe pull out very, very slightly. It drains for a little bit and then it stops. So in my opinion, at least, having a rough sense of how much pleural volume is in there before the procedure is helpful to guide what you do during the procedure. At least that's my personal opinion. And I think personally, I typically use the USA method just to keep it very simple to measure the pleural volume, especially for my general medicine walking wounded patients who can sit up. Right? This is not in the ICU where they're supine or ventilated. I can very simply have them sit up. Sorry, clear that. Take this measurement, multiply by 160, and I have my pleural volume estimation right then and there.
Yeah, actually, yeah. I mean, this is just, an estimation by the end. Each method has its drawbacks, and based on, methods. We can combine. Actually, I think there is a space to find a way to give like rough estimates easily. If we get like two lines, like one from here, and then we take another one from here, and then just do like a cohort. We might find something actually that give us like a clue what's going on, maybe as an estimation. This is like, we just combine like KCO2, and then we do like with a little bit of ASTA, and then Balik. We combine like almost 3, and then we, if we do like experimenting would be reasonable.
I'll also open up to the floor for any questions as well, or comments. Okay. Well, if there are no other questions or comments or anything you want to discuss, maybe we'll end the presentation there. And thank you once again, Rashed, for the excellent presentation.
Thank you all.
Thanks, Rashed.
Thank you.